is going to introduce our second speaker.
Thank you, John and Wei. I'm delighted to welcome Teiji Akagi from Okayama University from Japan. Hi, Teiji.
Hi, Michael. How are you?
I'm all right. So good to see you, and I'm so sorry that you can't be here, in person. But there you are, the virus and technology for us. So Teiji is a very senior colleague from Japan with enormous amount of work on catheter intervention and PAH, and we had many debates at the Cardiac Society meeting in Japan, trying to figure out who are the patients that may benefit from catheter intervention with PAH and primarily ASD. A graduate of Kirumi University who spent some time in Toronto. It seems that people have a choice between Toronto, maybe UCLA, Boston, and the Bromptons here in London, or London in general. So absolutely delighted to have you with us, Teiji. Thank you and welcome.
Thank you, Michael. And thank you for this kind of invitation. I miss visiting in London, but probably 22, right? 2022. So I'd like to start my presentation about PAH and specific lesions for that with left-to-right shunt when too close. I have no disclosure in this presentation. Pulmonary artery hypertension is an important factor affecting the long-term prognosis for adult congenital heart disease. Although new PAH-specific medications have emerged, there is limited evidence of whether these medications improve the prognosis of adult congenital heart disease patients with pulmonary artery hypertension. This is a beautiful review for the Margarita and Michael about recent PAH-specific medication for the adult congenital heart disease patients. Of course, we have several types of the PAH-specific medication, such as endothelin receptor antagonist or phosphodiesterase 5 inhibitors. These kind of the medications that works for the initial stage or the mild stage of the patient with mild pulmonary hypertension. However, even we use for these medications, majority of patients' pulmonary hypertension progress gradually, even under these medications. Finally, we need 2 or 3 PAH-specific medication. Still, patient pulmonary artery hypertension progress. So the medication is effective, but PAH pulmonary artery hypertension still progress in our practice. So this is one of the typical case in our series for the atrial septal defect with severe pulmonary artery hypertension. She's 34 years old female. She complained for dyspnea, syncope after exercise. Chest X-ray is revealed for the enlargement of the main pulmonary artery trunk, and electrocardiography shows a significant right ventricular hypertrophy. Echocardiography shows the atrial septal defect with severe pulmonary artery hypertension, increasing the right ventricular pressure. Left ventricle shows for the D shape for the interventricular septum. So the recent publication of the ESC guideline that demonstrated in patients with pulmonary vascular resistance more than 5 Wood unit, fenestrated ASD closure may be considered when pulmonary vascular resistance falls below 5 Wood unit after targeted PAH treatment and significant left-to-right shunt is present. So now that for this patient, class 2B consideration for the ASD closure, but this patient is almost 10 years presented by almost 10 years ago in our practice. So we use for initially her 6 minutes walk test around 200 meter. Her PA pressure was 106/32, mean of 58. Pulmonary vascular resistance more than 10 Wood unit, QPQS was 1.5. So we start for the bosentan because this is 10 years ago. We start bosentan first and we add epoprostenol infusion gradually increased. This is we increase for the dose for the very high dose of the epoprostenol, 110 nanogram per kilogram per minute. So we wait for the repeated, we evaluate for repeated catheterization. So finally, 4 years after the initial evaluation, her symptoms improved. 6 minutes walk test, more than 400 meter, but pulmonary artery pressure was not improved well. Still, pulmonary artery pressure was 82, mean of 51. However, pulmonary vascular resistance significantly decreased, less than 6 Wood unit. QPQS was significantly increased for 2.0. So we considered this is how pulmonary vascular bed is responded for these kind of pulmonary specific PH specific medications. We can manage for her pulmonary hypertension by this kind of medication. Then we decided to close for the ASD. Compared to the surgical closure, transcatheter closure have significant benefit for this kind of management. We can wait this under this condition. This condition means for the ASD was closed by the catheter, by the device, and pulmonary artery pressure was measuring about the Cranz-1 catheter. Usually we wait 15 minutes for this kind of situation, temporarily close for the ASD. So that if the hemodynamics stable or pulmonary vascular pressure, pulmonary artery pressure decreased a little bit, then we can decide to release for the device. So compared to surgical closure, transcatheter closure we can evaluate for the beating heart condition. In this patient, after the ASD closure, of course, the same medication was continued. However, significantly decreased for the mean pulmonary artery pressure was observed. This is the actual Har echocardiography. This is before the initial stage, before the pulmonary artery pH-specific medications. And after pH-specific medications, right ventricular chamber size a little bit to pressure was a little bit decreased. However, still interventricular septum shows a V shape. This is 6 months after the ASD closure. You can see the device here. And so just ASD closed by device, this kind of significant cardiac remodeling can be observed. This is the previous case series of this kind of strategies. ASD patient with pulmonary artery hypertension. 8 patients were treated by this kind of treat and repair strategy, pH-specific medications. These 8 patients age was young, mean of 35, all females, and systolic PA pressure was 100, and pulmonary vascular resistance nearly 10, and QPQS was 1.3. So these kind of the patient we use for the several types of the pH-specific medication, because it's almost a 10 years history. So the medication is a little bit different, but case by case. But basically, we need for the 2 to 3 combination medication. And recently, we use for the much more rapid combination, such so-called for the upfront therapeutic strategies. So in all of these 8 patients, pulmonary vascular pH-specific medication improved for the pulmonary artery pressure. Also, after the ASD closure, much more significant improvement can be confirmed. So that we think about this kind of the strategies, probably very effective for the ASD plus pulmonary artery hypertension. This is a review for the also the Brider and Michael. This commented treat and repair approach may have place in highly selected patients from gray zone. And also that we need for the very careful evaluation after the closure. So now we are doing for the nationwide survey in Japan, this kind of strategies. Probably we can close for the surveillance. Up to now, we have nearly 35 cases all over the Japan in this kind of the approach. One more different type of the shunt, ventricular septal defect. This is much more controversial. She's a 49 years old female. She had pulmonary artery banding at age of 4 years, but doctors decided for the out of indication for the VSD closure. Actually, she had 2 babies, and age of 40s, she increased for the cyanosis and edema. Her oxygen saturation was 88 at room air, even oxygen inhalation 92%. Up to then, she did not use a pH-specific medications. This is her echocardiography at initial stage. Very large VSD, 24 millimeter, and mean pulmonary artery pressure was 71, and pulmonary vascular resistance was 15. This is her chest X-ray and electrocardiography and CT scan. You can see the at the site of the PA banding and very enlarged for the main pulmonary artery trunk. We evaluate for the oxygen challenging test that her pulmonary vascular resistance has responded, and we use for sildenafil ambrisentan for 1 year, and resistance decreased 7.2. So we can decide it that we can close for the ASD by surgery, and at the time we made ASD fenestration. So her symptom was significantly improved. Also, pulmonary artery pressure was decreased, mean of 42. Now she also the very good condition without only we use for the oral pH specific medications. Now we summarize for the 3 case series, this kind of the VSD plus pulmonary artery hypertension cases, treat and repair, still limited experience. However, we believe for even in a VSD patient that this kind of strategy can be performed in the selected patient. In conclusion, when we consider the treat and repair strategies, at cath lab, we can evaluate for the acute evaluation. That is response for the oxygen or nitric oxygen inhalation. That is a very conventional evaluation for the response of the pulmonary vascular bed. But now we have a long-term evaluation. That means a combination for the pH-specific medications, 1 year, 2, something like a long-term evaluation. If the patient, if the repeated catheter evaluation for the pulmonary artery pressure or resistance, probably less than under the 6 or 8 Wort unit, we can consider for the treat and repair, closing for the defect. Such situation, patient improvement or cyanosis, or sometimes patient much more symptomatic due to pulmonary congestions. We didn't reach to the conclusion for the fenestration need for the required for this kind of strategy, or non-fenestration is much better for the hemodynamics. This is we need further evaluation. Thank you very much for your attention.
Thank you so much, Teiji. That's a wonderful talk. And just in case, I think it's not made quite clear, but this small number of high select patients that you close the defect with a good result comes out of a very large database. So they're highly selected patients.
Yes, I think so.
Yeah, and also to say that your early report in the European Heart Journal, many of us read with interest. Be very interesting in hearing the longer-term follow-up of this cohort, because
yes,
pulmonary hypertension, once you have it, is with you. John, do you have any questions or any comments while we're looking at our delegates?
Well, I just suppose, how high with a PVR would you attempt to close an AS? Is there an absolute limit that you wouldn't go above?
Anyway, we tried for the PH-specific medication in such patient. Even they clinically diagnosed for the Eisenmenger syndrome, we try to start. If the patient responded, usually we wait a few months and repeated cath lab and repeat evaluation for the pulmonary artery pressure, or especially for the pulmonary vascular resistance. So if the patient has much more severe type of the pulmonary vascular resistance, we add for the epoprostenol. That is only one way.
Okay.
Teiji, there's a question from Grusen Veltman, which is as follows. Which parameter do you consider most important in deciding treatability, meaning closing the defect? Pulmonary vascular resistance index, or vascular resistance, or the relationship between pulmonary and systemic vascular resistance? Could you please comment on that?
That's a very good question. And also very difficult to answer. Mostly that's kind of combination is very important. Also, right ventricular functions and patient age. Usually, patient very very sick, and also treatment is very tough for the patient. It need a time for the many repeated cath lab. So that is consideration is very important. But the most important factor is the pulmonary vascular resistance, I think.
Yeah, and I think this is quite a crucial thing, isn't it? And I think we made it quite clear in one of our review articles that maintaining the PAH definition for our patients comes with a lot of problems, both for those with PAH, large shunts, low pulmonary vascular resistance, and also the other end of the spectrum, obviously the Fontan patients that don't have PAH, but may have some of them abnormal pulmonary vascular bed. I think in the interest of time, maybe you should continue, John, and I think